Hello, everyone. My name is Grace Dennis, and I'm so happy to welcome you to the 7th Annual Cannabis in Practice webinar series, hosted by the Washtenaw County Health Department and the Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. To review some housekeeping notes, all participants will be muted throughout the session. Please use the Q&A box to submit questions, which will be answered at the end of the presentation. If you require a live transcription, select the Show Captions function. If you do not see it, please resize your window for it to be wider. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. This live webinar has been approved for 1 credit hour of social work continuing education, MCBAP credit, CHES credit, MISHWA credit, and CME credit. If you are requesting any of these continuing education credits, please be sure to stay until the end to fill out our post-webinar evaluation survey. None of the planners or speakers for this educational event have any relevant financial relationships with ineligible companies to disclose. And now I'm pleased to introduce today's speaker, Dr. Jason Kilmer. Dr. Jason Kilmer is a professor of psychiatry and behavioral sciences at the University of Washington School of Medicine and an adjunct professor of psychology at UW. At UW Center for the Study of Health and Risk Behaviors, Jason serves as an investigator on several studies evaluating prevention and intervention efforts for alcohol, cannabis, and other drug use by college students. In addition to research and teaching, Jason has worked extensively with college students and campus professionals about alcohol and other drug prevention programming, both at UW and over 150 campuses nationwide. Jason is the principal investigator of Washington's Young Adult Health Survey, now approaching its 12th year, evaluating the impact of cannabis legalization among 18 to 25-year-olds. I am so pleased to welcome Jason Kilmer, and I will now pass it on to you to start your presentation. Thank you again, and I hope everybody enjoys the webinar.
Great. Thank you so much, Grace. Happy Friday, everybody. Hello from Olympia, Washington. I will dive right in and share my screen. This has been a really, really great and cool team to work with, and I wanted to start by thanking them. I told Tess I was going to give a special shout out. Tess was so unbelievably kind, patient, and everything with emails coming at the height of our academic year. Tess, you're fantastic. Thank you. The whole team has been genuinely outstanding. I just want to thank them. I also want to thank all of you for doing what you do to support people in your community. And, prevention's always hard. People don't call us and say, hey, good news, nothing bad happened last night, so keep it up. But if God forbid something happens, the first question is, did you know about this? What were we doing about this? So thank you all for doing what you do. Not to teach to the test or anything, but the objectives that I had were to be able to identify a screening measure for cannabis use disorder. I'll be sure to draw your attention to when I'm introducing that. Identify at least 2 risks or outcomes related to cannabis use in health or mental health, and identify at least 1 guideline for lower risk cannabis use. On top of thanking Tess and the team, on top of thanking all of you, I'd like to thank Zoom. We couldn't do this today without Zoom. Plus, Zoom is gaining emotional intelligence. It's gaining empathy. You wouldn't think that's true, but it's true. I started to see it about a year into the pandemic when I was invited to present at an event. And when I got the link, the email link actually said, which is how I feel all the time. I was like, man, Zoom, you get me. And now everywhere I look, And then they sent me the link for today, and lo and behold, So I really feel understood by Zoom and 3 other people. Not gonna lie. Oh my God, I love that you're doing the little floating emoji thing. So that's really, really nice. So I feel like if you're coming at it from a clinical standpoint, one of the main things to even keep in mind is that the language we use is important. In Washington State, we had Initiative 502 approved in November 2012, and it was called, and I quote, the Recreational Marijuana Initiative. About a year into it, people were like, should we call it recreation? Because when you think recreation, you think hiking and biking and fishing and things like this. We don't really talk about recreational alcohol use. So they said, what if we call it adult use marijuana? 20-year-olds were like, you don't think we're adults? And they're like, good point. So we settled on making a distinction between medical and non-medical, and you'll hear me use those 2 terms. Then, a couple years further, the state found some pretty clear documentation that the term marijuana had been used for some not very nice purposes with some fairly racist intent, especially against groups of people from Mexico. And the state said, we can do better. So our state passed legislation at the state level that if we talk about cannabis at the state level, that's the term we need to use. What have we learned? Not all of our clients, patients, students know what that word means. I used to work in a student affairs office where you would screen and ask, have you used any cannabis in the past 6 months? And people would say no. And with nothing to hide, once they met with us, they'd say they use weed every day. And we're like, hold up, you said you don't use cannabis. They're like, I don't know what that is, but I use gummies. You want a gummy? So if you, at the end of the day, use the word the human being across from you uses. If someone says, I smoke weed, you can call it weed. We wouldn't stop them and say, I'm sorry, could you please call it this? But also keep in mind that what verb you use matters. If you ask someone, do you smoke marijuana? Someone that uses edibles every day can say nope, and they're not lying, and we've missed their daily use. So keep in mind, and you've likely heard this at some of the other presentations, so I apologize if any of this is review, but it can be smoked in joints, bongs, pipes, blunts, spliffs. It can be vaped. There are vape pens, vape devices, vaporizers, orally ingested, brewed as a tea, infused drinks, gummies, cookies, brownies, in quotes, edibles. And there are very high potency concentrates. Dabbing is now a verb for when people use dab pens. Wax, hash oil, butter, which looks like what you spread on toast, but it's spelled with two D's and it's certainly not the dairy product. Shatter looks like broken glass. These are very high potency concentrates, and I'll be talking about that. If smoked or vaped, people feel it pretty immediately. And if orally ingested, there's more of a lag. 30 to 60 minutes is talked about in the published literature. Retail stores tend to warn people about the potential for a 2-hour lag. If people say, I use weed and I get high, what's likely driving that is delta-9 THC. That's the cannabinoid most associated with getting the high. CBD, not generally seen as intoxicating, but what we've certainly learned after legalization is it doesn't often contain what the package advertises, sometimes including THC itself. Delta-8, Delta-10, other synthetics. These are intoxicating, often orally ingested. They're not regulated. They're not FDA approved. And I hope what's very, very clear is that for safety and ethical reasons, we have very little research. We can't take people that have never used and say, would you be willing to take this? So we see what happens. So instead, you wind up learning from case studies, things like that about experiences people have. Now, you undoubtedly know your own community best. But at the end of the day, I hope I make a clear point about the data. These are data from the National Survey on Drug Use and Health, and they look at past year cannabis use by 12 to 17-year-olds, 18 to 25-year-olds, and 26 and older. 3 things to conclude about this slide. One is that I'd like to thank SAMHSA for putting me in an age group with 26-year-olds. Second, most people don't use, no matter what age group you look at. The overwhelming majority do not use. Yet there is this group of 18 to 25-year-olds that are the ones that if you're going to hear cannabis use reported, they're going to be at higher rates. 36.5% of 18 to 25-year-olds, meaning 2/3 don't use. If you look at the Monitoring the Future study out of your own state, this is the brand new report that was just released for 2024 data. Most people aren't using. My friend and colleague, Dr. Jeff Linkenbach, says we need to balance hope and concern. It's concerning. The 7.2% of 8th graders said they used cannabis in the past year. It's exceptionally hopeful. The 92.8% don't. 15.9% of 10th graders, a little over a quarter of 12th graders. When you look at current behavior, which we usually define as the past 30-day use, these numbers predictably go down to 4%, 9.5%, and 16%. I work on a college campus, and college students and young adults are the ones with the most frequent use. I will say again, most do not use. College students, 39.5% report past year use. You heard in Grace's very nice introduction, I'm the principal investigator of our state's Young Adult Health Survey, where we look at 18 to 25-year-olds. After 12.5 years of legalization, our rates are a little higher. We're in the upper 40s. Most people aren't using. Their non-college peers, a non-statistically significant difference at 38.9. Past month use, 26% of college students, 28.8% of their non-college peers. This is also not a statistically significant difference. Where you see a difference is in daily or almost daily use. 6% of college students, 11.6% using daily or almost daily with their non-college peers. And that is a statistically significant difference. Sandra Wolfson, 25 years ago, showed that the most pronounced misperceptions of cannabis use come from those that use most often. If you're talking to a client or patient that uses every day, they're probably going to tell you everyone uses weed. All those statistics are wrong. That's not the case. Study after study after study shows these very gross misperceptions. I learned that my most cited article is one that came out years ago now, where we surveyed almost 6,000 college students and asked, have you used cannabis in the past year? A third had. Two-thirds hadn't. So what do most students do? Most students don't use. When we asked them, what do you think the typical student does? Only 2% of students got that right. 2% of students said, I don't think most people use cannabis. All right, I just got a message that the host has spotlighted my video. That's a lot of extra pressure. Um, uh, and what was noteworthy is that 98% of students said, I think most people use cannabis. What we learned is the more pronounced that misperception was, the more likely people were to use frequently, and even experience consequences. What's the really, really, really good news? We can correct misperceived norms. Now, when you look at the impact of THC, and when you consider why the changes we've seen, especially after legalization, are so noteworthy, it starts to tell a pretty clear story. If you orient the brain, such the front of the brain's on the left, back of the brain's on the right, drugs that involve a high and that have an addiction potential, we tend to see activity in the reward pathway, but you can see very important parts of the brain associated with very important functions. Where does THC bind in the brain? All over the place. People have asked for decades, can cannabis affect motivation? I remember when I was a student, they talked about an amotivational syndrome. Want to make something sound scary? Call it a syndrome. And then go, dun, dun, dun. Motivation is really hard to measure. So we look at what's regulating motivation. What regulates motivation is the anterior cingulate cortex and the dorsolateral prefrontal cortex. Don't worry about the fancy terminology. Where's that in the brain? Right there. So when people say, I feel like when I use weed, I'm less motivated, I'm less driven, is that possible? It's absolutely possible. So, what do researchers consider the strong stuff? High potency cannabis? Anything over 10% THC. I will ask you to keep that number in mind. El Soli and colleagues. I got to go to a meeting where Dr. El Soli presented just a couple weeks ago. I totally geeked out. I wrote this really mushy email in the chat and then felt kind of stupid afterwards, but he's so cool. And he's been doing research for years that every time there's a seizure by the DEA in the illicit market, a sample goes to the University of Mississippi and they analyze it for THC levels, CBD levels, the ratio of THC to CBD, and if it's laced with anything. If you package this article with Dr. Nora Volkov's 2014 article, we can estimate cannabis potency going back to the 1970s. When you hear people who are older today reflecting on their time in the 1970s and they say that they, in quotes, smoked grass, it's because it was practically grass. 1% THC, maybe 1.5%. In the 80s, 2 to 3% THC. In the 90s, as you see, started at 4, trickled to 5, got to 6. 2000 continued to increase. Keeps going up and up and up and up. By 2010, we hit double digits, but then the chart runs out. They updated it, and they showed that in the illicit market in the United States from 2010 onward, there was this band between 10 and 15% THC that products genuinely fell in. But what about states that have legalized? The state of Washington agreed to go under a microscope looking at the first 2+ years of sales in Washington. This is only smokable flower, and on the y-axis is the percentage of total tax-inclusive sales. On the x-axis is month and year. What's that little baby blue sliver? Products under 10% THC. These have been virtually eliminated from the retail market. In brick red, 10 to 15, green 15 to 20, purple's over 20%. Cash and colleagues eliminated any doubt when they looked at states that had data in medical and non-medical markets. Colorado, 95.91% of their retail market is high-potency cannabis. California, which legalized for non-medical purposes but kept a robust medical dispensary market, they're only 0.01% off of Colorado. 95.90. The biggest visible difference is that a larger slice of the proverbial pie is 10 to 15%. In New England, you see a very consistent theme emerge. My state clocked in at the highest with 97.07%. I'm going to guarantee you, I hear from college students in Washington what you hear from the people you work with. It's natural. It's just weed. It's safer than alcohol. Smokable bud or flower. This is a document that came out in Washington in January, and I linked it. This will be in the handouts you receive. Smokable bud or flower, the common range sold is 20 to 30%. They've gotten to the point where they just said, now just count on it being anything under 35%. None of that occurs in nature. That takes intentional breeding of created high potency strains. Vape liquids can be even higher, but are typically up to 85% THC. We used to say that concentrates were 60 to 90. They bumped that lower bound, 70 to 90% THC. Not only does none of that occur in nature, that's not even the plant anymore. That's the sticky, gooey substance that has very little to do with cannabis flower. And what science is showing is that increase in potency is something that prevention specialists, healthcare providers, clinicians, should be aware of. DeForty and colleagues across 11 cities in Europe and Brazil showed that daily use of cannabis over 10% THC increases the odds of developing a psychotic disorder 4.8 to 5.8 times compared to people who don't use. If you're rounding, 5 to 6 times greater. Dr. DeForty joined us from Europe via Zoom in September for a cannabis summit we had at the University of Washington. And she pointed out we rarely get to use the word causal in research. She said this is a domain where we're starting to use the word causal. High potency cannabis causes psychosis. Lindsay Hines out of the United Kingdom showed that the more often people use cannabis, when she followed them up to the age of 24, the greater likelihood they were to get addicted and the more onset of generalized anxiety disorder. In Canada, they legalized nationwide for non-medical purposes, and they came out quickly to say, it's legal, that doesn't mean it's safe. For concentrates, people need to know it's associated with more problematic cannabis use, more addiction, cannabis use disorder, and more mental health disorders. And finally, I'm a state employee. We are reminded, especially at election season, it's a state ethics violation if we come out for or against a candidate or an initiative. So we tend to be very, very quiet and only speak when spoken to. We got spoken to. End of 2019, started 2020. The state said something feels like it's changed with these high potency products. They said we want researchers to weigh in on this, but we don't want any one researcher to do it because it would be way too easy for that person to be accused of bias. They'd probably get eaten alive. We don't even want one university to do it because what if they handpick their friends and there's not a lot of critical thinking? The state almost jokingly said, the University of Washington State University, your rivals, you didn't agree on anything. What if we got researchers from both schools, and only if you can all agree on a consensus statement will it ever see the light of day? I was honored to be one of the researchers they invited. I'm not going to lie, I was stunned at how quickly we came up with a consensus statement. You'll be able to go to this link that'll be in your handouts, and you can download our entire 20-page report. If you don't have time to read 20 pages, I'm with you. We have a 2-page Cliff Notes version. Cliff was my favorite author when I was younger, so shout out to Cliff. We even have slides you can download. But what we concluded is that these high potency products are no joke, especially before the age of 25. Adolescents, teenagers, young people, college students, young adults, because of brain development in particular, the more often they use these products over 10%, the more they're experiencing a range of unwanted risks, outcomes, and harms, including the risk of developing cannabis use disorder or addiction. So I tried to pick 4 domains relevant to mental health in particular, as well as education, prevention, public health that surrounds mental health as we go through this. I feel like I should pause. Hey, Tess, I know you, or at least one of you was looking in the chat, especially if there's any clarifying questions before I get too far away from the original slides. I'd like to see from the moderators if there's anything clarifying that needs to be addressed.
No clarifying questions. There was just a request for handouts, which you've
Oh
already.
yeah, and I'm sending those as soon as we're done. Absolutely. Cool.
Yep.
Thank you. Sorry to bug you. So if someone said to me, you get to show one slide to college students, I would show this next slide I'm about to show you. The part of the brain that, among other things, affects attention, concentration, and memory is the hippocampus. Truly long story short, after cannabis use, the neurons in the hippocampus get suppressed. What does that mean? They fire, but they fire at a rate that is lower and slower than they could or should be firing. Harrison Pope is a Harvard researcher that said, I want to test this with college students, but I don't want to get people super high and make them take a test. That's not good research. I want people to use cannabis, and I want to test them 24 hours later. What did he find? A full day after use, there were measurable decreases in attention, concentration, and memory. And the more often people used, the more pronounced these decreases were. There seemed to be an additive or cumulative effect. Researchers did the slow clap. It's like, wow, that's a game changer. Critics said, is it a game changer? It's not causal. What if people who struggle with attention are attracted to cannabis? Dr. Pope said, that's fair, and we can test that. Ethically, we can't take people who don't use and make them start to see if we can induce cognitive decreases because that's unethical. But what if we take people that are using every day and have them quit? If we follow people over time and their cognitive abilities stay the same, maybe they were there to start with. But if as they abstain and as we follow them over time, their cognitive abilities improve, that, my friends, is causal. It takes 4 weeks, 28 days. But 28 days after stopping daily cannabis use, this all goes away. Performance on attention, concentration, memory matches that of people who don't use. Down in California, Hansen and colleagues showed that among a sample of 15 to 19-year-olds who used on average every other day, verbal learning took 2 weeks of abstinence to match that of their peers who don't use at all. Verbal working memory takes 3 weeks of abstinence. Attention takes the full 4 weeks. Think of what this means. Like, I don't know the full age group of who everyone works with, but think of what this means if someone that you're working with has ADHD, if that's been diagnosed and they're prescribed something for it. Cannabis is a horrible fit because we know of no substance more associated with causing attention decreases, let alone worsening existing ones. You will likely hear some of them say, as I hear college students say, I think you're wrong, because when I don't use, I can't sit still. That's withdrawal, and I'm going to talk about that in a bit. We have no idea why, but June 2024, the word of the month in Seattle clinics was disentangle. How come? We had more people actively coming into clinics saying, I'm pretty sure I have ADHD. Can I get a stimulant prescribed to me? Who to a human were using cannabis. What clinicians were advised was this: encourage your client or patient to abstain for 30 days so that we can disentangle, there's the word, what is an actual underlying attention issue from just the side effect of their cannabis use. It has officially become challenging to diagnose attention issues if people are using cannabis. And finally, if someone says, if you're working with students who say, I want to do well in school, but my attention's off, my memory's off, I can't focus, calling time out on their cannabis use will lead to improvements. This continues to be replicated over time. In January, in JAMA Network, a study said we want to look at if recent cannabis use and lifetime cannabis use is associated with differences in brain functioning during cognitive tasks. They showed that both recent and heavy lifetime cannabis use were associated with diminished brain activity and cognitive performance during working memory. This is huge for people with jobs, with school, with student athletes, you name it. And what we find is that in K through 12, both alcohol and cannabis impact things like dropping out, academic success. It doesn't go away when they get to college. The more often people use cannabis, the lower their grade point average tends to be. The more classes they skip, the less likely they are to still be enrolled. When followed over time, the less likely they are to graduate on time. Number 3 is the impact of substance use on sleep quality. You will likely hear people say, I use cannabis at night and I fall asleep faster. They're telling the truth. Cannabis has both sedative, sedating, and hypnotic, sleep-inducing properties. So if someone says, I use weed and I fall asleep more quickly, they're telling the truth. Ask them, though, on nights we use cannabis, what do you notice about your sleep? You can even be more directive. Tell me about your dreaming. You're going to hear 2 things. 1, I sleep hard. I sleep and I mean it. And I don't dream. Here's why. If you want to have a perfect night's sleep, REM sleep is rapid eye movement sleep. It's where we do our dreaming. Non-REM are the other stages of sleep. And I know that there's some discussion about renumbering or renaming stages, with one exception. What we've historically called stage 4, deep sleep. So the bottom, deep sleep, the top, REM sleep. What does a perfect night look like? REM gets longer, longer, longer. Deep gets less and less and less. If someone uses cannabis at night, what happens? Angarita and colleagues showed that stage 4 or deep sleep gets extended, and there's no REM. Why do they say they sleep hard? They describe subjectively the extra time in stage 4 as somehow getting like intense sleep. Why don't they dream? There's no REM sleep. What's the impact of a night of REM-deprived sleep? We see a predictable increase the next day in sleepiness, anxiety, irritability, and jumpiness, all packaged nicely with a quality of sleep that wasn't so hot. Think about what your clients or patients are seeing you for. How many of their presenting issues involve the words you see on your screen? If they use multiple nights in a row, these effects are additive or cumulative. If they take a night off, the body plays catch up. Everybody in this meeting has had the next night's sleep. whether you've ever touched a substance in your life or not. Why do I know that? Because lots of things cause REM deprivation, including not sleeping, sleep deprivation. Think of the last time you were up all night or only got an hour or two of sleep. The next day, if you can pull it off, you sleep for 9, 10, 11 hours. How do you feel when you wake up? Tired, groggy. How do you feel tired? You got 11 hours of sleep. Because quality different than quantity. I can't graphically show you insomnia any better than right there. A person slams so fast into deep and immediately into REM, this rapid cycling leads to difficulty both falling and staying asleep. Some people say they can't turn off that running commentary in their head. Some people say they're more tuned into that noise outside, or they're more actively focusing on the ticking of the clock on the wall. Or really, person next to me, breathe louder if you could. Plus, once they get to sleep, too much time in REM, not enough time in the other stages of sleep, we see an increase in fatigue the next day. It's not even until the next night the body sleep cycle approximates something normal. So if someone's seeing you and saying, I have no energy, I feel like I've got a weight on me, I'm irritable, I'm on edge with family members, I'm tired all the time, and I'm anxious. That's why I use weed at night. The brutal irony is that that nighttime use could be causing these very things. And what the science shows is calling time out on cannabis use. You will see sleep quality improve, and the words you see on your screen will improve, if not be eliminated as well. Number 2, factors associated with health and mental health not already addressed earlier. In my eyes, planet Earth's single biggest cannabis expert is Dr. Wayne Hall at the University of Queensland. He is so cool. And his article with his colleague Louise Degenhart in 2009, one of the 10 most cited we have in our field. He was the first person to say, especially if you're working with kids, prevention matters in a big way. They showed that those that use cannabis 10 or more times by the age of 18 were 2 to 3 times more likely to be diagnosed with schizophrenia. Think about Dr. DeFordy's research and how much that really solidified this finding. They said, we think 13% of schizophrenia cases could be averted completely if cannabis use didn't happen. I had the honor of moderating a webinar with Dr. Hall in April 2013. We'd only had legalization a little over 4 months. And I asked him, if we could do one thing on college campuses in Washington, what should we do? And he said, I would screen for cannabis use disorder. This is one of the objectives, by the way. I asked him, why would you recommend screening? He said, I don't know what comes first. We don't know what drives what, but we see a terrifying 3-way relationship between depression, cannabis use disorder, and suicide. That is so strong that if someone willing to admit to you, I'm looking for help for my depression, flags as being addicted to cannabis, this person poses a suicide risk that we cannot explain. He said, if you have a wait list, don't put them on the wait list. They become number 1 priority for an assignment to a provider. I asked him, what do you recommend for screening? And he said, the QDIR, the Cannabis Use Disorder Identification Test Revised. This has been deemed to be reliable and valid across many different cultures and nations, which is important if you're working with a diverse client or patient group. The state of Washington, the Washington Recovery Helpline, got permission for the authors to get this out there for providers. So this link will be in your handouts. It starts with a simple yes, no. Have you used any cannabis over the past 6 months? I mentioned earlier, we learned we had to define when we say cannabis, this is what we mean. If no, you're done. If yes, there's 8 questions. And if you can see my cursor, how to score it will be in your handouts right there, how to interpret it right here. When that webinar got done, I said to him, I feel like I can't stop thinking about what you said. I had no idea. And he said, well, look at your own country's data. So I did, because I really wanted him to like me. And this is buried in pages of tables in the National Survey on Drug Use and Health. It is not causal. But look at this dramatic relationship. In this bluish purple, it's people 18 and older in the US with a past year cannabis use disorder. In yellow, people with no past year substance use disorder. Serious thoughts of suicide, almost 6 times greater. Making a suicide plan, 7.5 times greater. Attempting suicide, over 8 times greater. I hear people say, well, you can't overdose on weed. That's not true. It looks different than an alcohol overdose, an opiate overdose. There's hyperemesis, which is aggressive, violent vomiting. And we also see an acute toxic psychosis. And sadly, you can plot ER visits and poison center calls for acute toxic psychosis alongside the increase in potency. People could see things that aren't there, hear things that aren't there, feel things on them that aren't there, so hallucinations, delusions, including being super paranoid, and complete out-of-body stuff, depersonalization, that we normally see with dissociative drugs. What causes this? If people use too much or if potency is too high. I have lived in Washington State my whole life, and it is sad to me to say that I live in a state in which drugged driving deaths outnumber drunk driving deaths. The authors of our legalization initiative set DUI at 5 nanograms of THC per milliliter of blood for those over 21 and any positive amount for those under 21. Why'd they pick 5 nanograms? It's not the same as being legally intoxicated with alcohol, but you do see similarities in reaction time impairment as you do at 08 and the ability to shift focus when there are multiple competing stimuli, lights, pedestrians, other cars, animals. How long does it take to drop below that point? The best research we have, people need to wait 6 to 8 hours after smoking, vaping, inhaling, 8 to 12 hours after oral ingestion. Retail stores in Washington opened in 2014. 1 year later, fatalities with THC present almost doubled. In 2017, we became a state in which drugged driving deaths outnumbered drunk driving deaths. And if a picture's worth 1,000 words, this is a grim graph. This is not DUIs. This is not police activity. This is drivers involved in fatal crashes in Washington who are THC positive. Stable, 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 stable. There's legalization. Up, up, up. If you're working with people for whom they just got their license, or, they certainly involve driving for their job. A healthcare provider's ability to make sure you can at least issue a warning about impaired driving can matter. They will listen to you. And people don't drink and drive when you hear things like, I drive better when I'm high. They really don't. They may try and try harder to compensate. The science shows it's not resulting in compensating for these. You could have an entire hour-long webinar on cannabis and birth outcomes. Again, I didn't know the range of providers at this meeting. Obviously, with so many of you, there's the likelihood you do work with people who are pregnant or intending to get pregnant. This is heavy research. Coleman Calger and colleagues published an article that got a lot of attention when they looked at people that use cannabis during pregnancy, tobacco cigarettes during pregnancy, or both. And they showed significant differences in head circumference. The group that used both tobacco cigarettes and cannabis, 5.7 times greater odds of having a small head circumference in the newborn than the no-use group. Occurrence of birth defects were 3 times greater in the co-use group. Not a typo. Among people that use cannabis during pregnancy, there was a 12 times greater odds of stillbirth or miscarriage compared to the no-use group. They said there are massive limitations in the study, and that really the study we're all waiting for is a matched study where you look at newborns who were cannabis exposed and those that were not. Bailey, Wood, and Shaw changed everything. They looked at 531 marijuana-exposed newborns and then 531 controls. And they matched them on delivery year, delivery hospital, maternal age, if the marital status, if they had insurance or not, other drug use, and so on. There's a lot going on this. And big fans of statistics will quickly look at this and go, whoa. If you're not a big fan of statistic, totally okay, and let me walk you through this. These are the 7 outcomes. These are the scores for the non-marijuana exposed 531 newborns. These are the marijuana exposed. These are the odds ratios or differences, the significant test. And on the far right, the p-values. Anything less than 0.05 is statistically significant. All of these are less than 0.05. They concluded in the current study, marijuana exposure in utero independently predicted poorer birth outcomes across the board, especially indicators such as birth weight and preterm birth that are known to impact longer-term health and development. Effects could not be attributed to other comorbidities, including other drug exposure and sociodemographic risks in the study that involved rigorous matching and biochemical verification of self-report of marijuana and other drug use. Consequently, women should continue to be encouraged to avoid marijuana use during pregnancy. I do a lot of work with student athletes. I could also do an hour-long talk on this. Just to give you some highlights, Stoll, Morse, and McDuff said THC and CBD are not performance enhancing, they're performance reducing. They artificially increase heart rate and blood pressure, they decrease work performance, they interfere with steadiness, reaction time, and psychomotor performance. Arguably one of the most impressive articles, because of where it came from, was Sharon and colleagues in Canada. They said, look, it's legal here. What do athletes need to know? They concluded that cannabis use decreases performance overall, reduces ability to maintain effort, reduces physical and maximal work capacity, increases heart, breathing rate, and oxygen demand, throws off balance, and as a verbatim quote, should be avoided in order to maximize performance in sports. If you work with college athletes or you're a fan of college sports, you probably saw that last summer the NCAA said, we're not going to test for cannabis anymore. How come? What do they test for? Performance enhancing drugs. The NCAA said, we can't find a single study that suggests that it does anything other than hurt performance. If a student athlete is already punishing themselves and their teammates, why would we punish them twice? So I think it's important if you're working with someone for whom staying in shape or just athletic endeavors are of importance to them, you can let them know. And number one, addiction risk and withdrawal. I get asked all the time, is weed even addictive? Yes, very. Then people go, is that new? No, the terminology has changed. In the old days, 2012, we had the DSM-4, and we talked about substance dependence and substance abuse. In 2013, when the DSM-5 came out, right, we bailed on the Roman numerals. Take that, Rome. Rome may have had nothing to do with it, but they got rid of the Roman numerals. They called it substance use disorder. And in the case of cannabis, cannabis use disorder. And there are criteria. And based on the number of criteria people endorse, they get a rating of mild, moderate, or severe. I hope none of you mishear me. If you have a friend, a family member, a loved one with a gravely disabling or potentially lethal condition that's had medical cannabis recommended and they're using as recommended, bless that person. That's not who I'm talking about. I really, really worry about the very depressed 18-year-old who says, I'm not going to talk to a clinician. I'm not going to go to a counselor. I've got a medical marijuana card. I'm good. I really, really worry about the person that says, I know things have been stable. I'm going to quit taking all my meds because I don't want to put chemicals in my body. I'm going to use cannabis. It's natural. I got a medical card. Here's why. I had the honor of presenting in Canada the week that they legalized nationwide for non-medical purposes. And the irony was, as they were getting ready to open the floodgates on access to non-medical cannabis, the medical community was saying we've got to slow down on medical cannabis. And since none of us should ever get our science from gizmodo.com, I went to the original article. If this is remotely of interest to you, this is a must read. Allen and colleagues said, what's the key to medication? Well, there are several. Let's look at four. Do the benefits of the medication outweigh the side effects? You all know this. Do the benefits of the medication outweigh the side effects or consequences? What's the addiction potential? We certainly worry about that with opiates. Has it been studied in randomized controlled trials for what it's being used for? And are there effective therapies or treatments out there? They said, we're going to make this easy. Notice the title, Simplified Guideline. They said, we want this flow chart to be in every healthcare provider's office in Canada. If someone says, hey, healthcare provider, can I get a medical card? Is that what they're asking for? This was really hard for me to read. I retyped it over here. Is it for neuropathic pain, palliative and end-of-life pain, chemotherapy-induced nausea and vomiting, or spasticity due to multiple sclerosis or spinal cord injury? If no, we're done. We're not giving it for anxiety. We're not giving it for depression. We're not giving it for sleep. We're not giving it for headaches. How come? Any benefits, if there are any, are so clearly outnumbered by the well-documented risks, consequences, and side effects. It's a very addictive substance. The science for those issues is not there. And for those of you who do therapy, provide prescriptions, provide treatments, from the bottom of my heart, thank you. And guess what? Therapy works. Treatments work. If yes, have they first tried those traditional therapies or treatments? If no, go back to the drawing board. And only if yes, consider a medical cannabinoid as an adjunct, but they say heads up, people don't smoke their medicine. If at this point in the presentation you're thinking to yourself, wow, this Jason Kilmer has some strong stylus skills, you would be right. The first time my stylus shot out of my computer, I was like, oh no, I broke my computer. My friend said, that's a stylus. I said, I don't know what that is. She said, Jace, you have a touchscreen. I'm like, I do? She said, you can draw on your computer, and now I can't be stopped. So on top of all these amazing special effects, I drew this Sasquatch for everybody, giving a little love from Washington State. I made this orca. Come on. That was amazing use of my office hours. I grew the greatest animal of all time, a Tyrannosaurus Rex, and then I put them all together into one majestic nature scene. I really need a hobby, everybody. See, I told you Zoom's one of 3 friends that I have. And my stylus, that's the other one. People say, what about CBD? That works, doesn't it? That's a research question. Arndt and DeWitt did a brilliant experiment where they had people sign a consent form and say, I agree to use CBD. It was a double-blind experiment. They eliminated expectancies. People didn't know what they were taking, and the person bringing it to them didn't know what they were bringing them. There were 4 conditions: sugar, 300 milligrams of CBD orally, 600 milligrams, wait for it, 900 milligrams of CBD orally. People didn't know what they were taking. They would take something, wait for it to kick in, and they would have them go through tasks that induced unwanted mood, affect. They got them upset. They got them anxious. When people didn't know what they were taking, what did CBD do? Nothing. I hope none of you mishear me. I'm not saying CBD does nothing, period. Allen and colleagues showed 4 domains in which medical cannabinoids could be indicated. But quoting verbatim, oral CBD does not alter responses to emotional stimuli or produce anxiolytic. What does that mean? Anxiety-reducing like effects in healthy human subjects. Finally, my favorite study from 2022, Jody Gilman. She did the study we've all been waiting for. You don't need a medical marijuana card if you're over 21 and have cash to go to a retail store in my state. But if you have a medical card, it's cheaper. There are fee exemptions, tax breaks, and so on. She looked at people in New England that said, could I please get a medical card? And if they were eligible, she randomly assigned them to get it immediately or be put in a 12-week waitlist control group. It was the first study to see what does getting medical cannabis buy you over and above those that don't. Probably not surprisingly, the group that got the card immediately increased their frequency of use. But guess what else increased? They got addicted, especially if they were using it for depression or anxiety. If a picture's worth 1,000 words, this one speaks volumes. What got worse? Cannabis use disorder symptoms. What got better? People said, hey, I'm falling asleep faster. We talked about that. Onset is more rapid, quality gets destroyed. Look at what didn't change. Quoting verbatim, there were no observed benefits of obtaining a medical marijuana card for pain, anxiety, or depressive symptoms. If you've got people saying, I'm looking for help for pain, anxiety, or for depression, we have so many different evidence-based strategies that work, and cannabis is not having the outcome in published research that people were hoping. So it's getting them connected with effective evidence-based strategies. And the last thing I'll say before I get us over the finish line, I worry about how many people say weed helps my blank, and what they're describing is managing withdrawal. Dr. Christine Lee asked incoming first-year students. The article said to a large Northwest university. It was us. Tell us why you use marijuana. And they said, I like getting high. I like the feeling. It gives me something to do with my friends. Helps when I'm bored. Makes things more fun. Music sounds better. It's cool. Helps me celebrate. But they also said it helps me relax, helps me sleep, lets me cope when I'm depressed. It relieves stress, helps when my appetite sucks, reduces anxiety, alleviates physical pain, helps when I have a headache. Is cannabis addictive? Yes. One of the criteria for cannabis use disorder is withdrawal. What do the criteria for withdrawal include? Keeping this list in mind, it's literally the same list. Anxiety, sleep difficulty, decreased appetite, depressed mood, and headaches. If someone tells you it helps my anxiety, because when I don't use, I get anxious. And if I use again, my anxiety goes away. That's withdrawal. And that's resuming use, making withdrawal symptoms stop. I told you 50 slides ago that people with ADHD sometimes say, if I don't use, I can't sit still. Look at criteria number 5, restlessness. That's withdrawal. So 3 suggestions you can do with as you wish. And I snuck it into actually a couple extra. Parents, caregivers, and guardians can be partners in prevention. In my state, sophomores in high school. Hey, kids, do you think your parents think it's wrong or not wrong if you use marijuana? What kids say, I think my parents would think it's wrong. 13% have used it in the last 30 days. When they say my parents wouldn't care, 59% have used. In our young adult health survey, we just shared with the state our cohort 11 data, but these are 18, 19, and 20-year-olds that have used cannabis in the past month. In yellow, it's all the sources that are going down. In blue, it's the sources that are going up. If you can see my cursor, getting it from parents with their permission has significantly increased to the point where in 2023, it became the 3rd most common source of cannabis for 18, 19, and 20-year-olds. It stayed that way in the 2024 data. I think look how we spent the last 44 minutes. I don't think that caregivers, guardians, and parents understand the mental health risks, the health impacts, and I certainly think they may be operating off of an old script, because I've heard too many parents say, I used weed when I was younger and I turned out fine. They used different stuff. You undoubtedly have your own resources, but if you want to play on the internet at work, and let it count as work, that's always a good day. Check out starttalkingnow.org, available in 38 languages. It's an amazing resource that we have here in Washington. I have fallen in love with refusalskills.org. It's an incredible They use kids in the development of this. Came out of Mike Graham Squire and Neighborhood House here in Seattle. Learn about cannabiswa.org/parents. These will all be in your handouts. And then out of Maryland is College Parents Matter. You go to topics, click on cannabis, and it's a choose your own adventure. They say parents, caregivers, and guardians need to know. Don't be afraid to talk about this. You're allowed to disapprove of substance use. Banish any fear that disapproval is naive. Focus on one message during the conversation. Reject the myth that discouraging it is useless because everyone's doing it. Let parents, caregivers, and guardians know the norms. Make communication a regular activity and recognize the power of your influence. I was in high school from 1983 to 1987. So first, I love Duran Duran. And second, I love all references to 80s music, just to show you how truly influential some parents can be. I'm married to a now retired sixth grade teacher, and right before she retired, she was grading papers, and I'm like, can I please take a picture of this? She said, only if you take the kid's name off, and of course I did. She gave the kids a blank map of the world, and the assignment was label every continent and label every ocean. Either this kid was hilarious or they also had parents from the 80s that may have broken their child, because one of her sixth graders labeled Africa as Africa by Toto, which is, of course, the song about blessing the rains down in Africa by the band that also sings the song Rosanna. Number two, consider screening, brief intervention, and referral to treatment. You have a screening tool. You can universally screen for cannabis use and cannabis use disorder. Miller and Rolnick's motivational interviewing can be implemented to raise awareness of what's going on, prompt consideration of change or commitment to change, and refer to treatment when needed. I was a co-author on a study that showed that in-person, personalized feedback interventions using motivational interviewing successfully reduce cannabis use, time spent high, and consequences. Within motivational interviewing, one of the things they encourage is to ask open-ended questions. And if you want your client or patient who uses cannabis to consider negative consequences or problems, we probably wouldn't use those words. Start by asking, what are the good things about marijuana for you? They will be delighted to tell you. After you get all that, ask them, what are the not so good things about marijuana for you? We have so many people on, I won't ask you to plug your number into the chat, but I run the mandated student groups at the University of Washington for students who have violated our campus drug policy for cannabis in a state that's had legal weed for 12 and a half years. When I ask 4 to 8 undergrads, usually 2 of whom are pretty big fans of weed, what are the not so good things about marijuana use for you? How long a list do I get? I'm going to guess if you were in front of me, I'd be seeing a lot of this, like short, 1 or 2 things. Just to make the point, 2 back-to-back groups, I eliminated the duplicates. There's my list. I get surprised when people say, well, you can't talk to young adults about weed. They don't see any problems. That's not true. It's what we call them. If I say, what problems have you had with weed? I don't have a problem. You got a problem. What negative consequences have you had? Literally this, having to meet with you. What are the good things? What are the not so good things? Because MI is label-free, judgment-free, that's going to result in a functionally different conversation. You can ask what would it be like if some of those not so good things happen less often. Any positive answer is what Miller and Rolnick call change talk. And if you ask what would make some of those not so good things happen less often, anything the person identifies is a client or patient identified strategy for behavior change. One of the learning objectives, identify at least one guideline for lower risk use. This is planet Earth's, I think this is planet Earth's biggest experts on cannabis. There's Dr. Hall, who I mentioned earlier, the Netherlands, single biggest researcher right there. Notice the title. It doesn't say low risk guidelines, it says lower risk guidelines. How come? They say you need to know there's no universally safe level of cannabis use. The only reliable way to avoid any use is to not use. If your client or patient makes the choice to use low potency products where possible. No, there's no one safe route of use. Every route incurs risks. That said, smoking is most risky. If people are insisting on using, finding a method other than smoking. Keep use occasional, a day or 2 a week, weekend only. If they say, I only use every other day from a risk standpoint, that's pretty risky. If you notice the cognitive stuff, stop. If stopping is not realistic, substantially reduce frequency and potency. There's that reminder to avoid driving 6 to 8 hours after inhaling, 8 to 12 hours after edibles. For people who intend to get pregnant, who are pregnant or breastfeeding, abstinence is the only recommendation. And lastly, There are some people that might want to avoid using or at least seriously adjust their use. Who's that? People with a first-degree family history of or who are actively dealing with psychosis, a mood disorder, or a substance use disorder. I added at the last second, do correct misperceived norms. Most people aren't using. Most aren't driving under the influence. And when people think everyone uses, they're more likely to use themselves. You can do that in personalized normative feedback, personalized feedback interventions. Jeff Linkenbach's positive community norms approach has been used in my own state. We're using data from our young adult health survey. We let people know most aren't using, most aren't driving under the influence. This is the Most Steer Clear campaign from Mike Graham Squire. And I'm going to end with this. Realize that what you do clinically, through prevention, through intervention, impacts so much in so many ways throughout your community. I have given you lots of academic resources, and I will end with a non-academic reference. It comes from one of my favorite stories from when I was a kid. It's about to turn 100 years old, and it's from the book Winnie the Pooh by A.A. Milne. When you wake up in the morning, Pooh, said Piglet at last, what's the first thing you say to yourself? What's for breakfast, said Pooh. What do you say, Piglet? I say, I wonder what's going to happen exciting today, said Piglet. Pooh nodded thoughtfully. It's the same thing, he said. When people say, I didn't come to talk to you about my weed use, I came to talk to you about mental health, it's the same thing. When someone says, well, what I really need is help with my anxiety, it's the same thing. What you do about cannabis use will pay dividends in so many different domains. I was asked to wrap up at the 50-minute mark. It's the 51-minute mark. Sorry for that extra minute. But I want to say one more time what an amazing group this team is. You all have been a joy to work with. From the bottom of my heart, I hope this met people's needs and expectations. My email address is jkilmer@uw.edu. So if there are articles you're trying to find, anything I can send your way, I hope you let me know. So I promised I'd stop sharing my screen so that the team could share theirs. And with that, we'll tag over for discussion. I'll have to make sure that I sent you all my accurate title. When I saw that, I'm like, wait a minute, I got promoted last year. So we got to fix that. This says associate to professor.
Oh, well, my apologies. We have
That's okay. I was looking at that going, wait, I sent you all so much stuff. Where'd that come from?
Oh, well,
It's
thank
okay.
you for
It's truly okay.
clarifying. And thank you for the wonderful presentation, Dr. Kilmer. As you
You can
mentioned,
call me Jason.
thank you, Jason. We're now going to open it up for questions, as you mentioned. We do ask that all questions be submitted through the Q&A function, which can be found at the bottom of your screen. And then as a reminder, this webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana in the coming weeks. So moving over to questions, something I didn't clarify earlier when I asked about handouts was whether or not those handouts would focus on the potency risks and like correlation to psychosis or any resources for that specifically.
I'll send you the PDF of my slides. I'm not sure I understand the question. So what's the hope?
If there are handouts or items that could be provided to folks for potency risks and related to psychosis.
Yeah, so I put the link on that thing that came out in January in Washington State in the handouts, and so you'll have that. That was the one that showed the different products. That was something that just came out in January for providers to be aware of because it shows the research as we understand it within the past 6 months related to things like psychosis. So that's coming.
Another participant asked, what would be an appropriate way to ask if someone consumes cannabis in any way?
Exactly that. What does your cannabis use look like, if at all? I'd ask it open-ended. What's scary is so many closed-ended questions can be very leading. Hey, before I prescribe this to you, you don't use marijuana, do you? Who's going to say yes to that? Yeah, I'm going to go with no, doc. Thanks for asking. Versus, what does your marijuana use or cannabis use look like, if at all? I don't use. There you go. Oh, I use a little. Tell me about your use. Well, I vape twice a day. Well, now we know that it's much more than a little, and you get a sense of frequency. It's a great question.
This participant says this might be a bit more of a niche question, but it comes up in
favorite kind
that they work with. Any thoughts on use of THC for those with restless leg syndrome?
Say, go where the science takes you. When people say, if I don't use, my restless leg syndrome is worse, that could be withdrawal. Because you saw that restlessness is one of the withdrawal. So if they make the backdoor conclusion that it must be helping, because whenever I don't use, it's more pronounced, that could be withdrawal. So when in doubt about what to use medically, keep in mind that in the United States, it's a Schedule 1 drug. Who knows if that will change? But Schedule 1 means there are no medical indicated uses. That's why states have done their own thing. So, the best research needs to involve evaluating its use medically. We can't really do that in the US the way that other countries might be able to. I cited Allen and colleagues because it came out of Canada. That article felt like a game changer. And the fact that they released that literally at the same time they were increasing access to non-medical use felt really powerful.
Thank you. Going back to the statistics related to drugged driving fatalities, someone's asking for clarification on whether or not it's clear that no alcohol was involved for the drugged driving cases, or if it was a mix, if that's something you have access to.
So we have now data thanks to our Washington Traffic Safety Commission. They have a dashboard. It is arguably one of the most grim data sets to play in because it's all the data on exactly that. We now see that poly drug use is the leading cause of driving fatalities in Washington state, and the most common two drug cause is alcohol and cannabis, such that the effects overlap. We really think people don't drink and drive. Even 12 and a half years into legalization, we know there's a lot more we can do about driving after cannabis use.
Thanks. Sorry, there's a lot of questions.
Do lightning round. I'm trying to answer as fast as I can. And I did see the one comment asking me to go slower. I'm sorry if I was going too fast for folks, but I tried to make sure I got through all 124 slides.
Yes, that's what we mentioned to them as well. Someone asked, is there much research on cannabis and breastfeeding? The non-expert consensus online seems to be that weed breast milk is better than formula.
I'm guessing that came in before I showed those slides that said the current recommendation we have, people should not be using cannabis during any kind of breastfeeding. Jamie Lowe, last name is literally L-O, at OHSU, Oregon Health Sciences University, I would argue is US's biggest expert in this. And Dr. Lowe has a number of research briefs. You know what? While you ask the next question, I'm going to put the link to their research briefs in the chat because they even have one that she did on this exact topic.
Perfect, thanks.
Yeah.
And we've got time for maybe two more, but we'll do this one. When it comes to educating the general public, what is the most important message we can say about the harms of teen cannabis use? For example, in a public awareness campaign message.
I mean, know your own audience best. And I think that could differ. You know, if I was working with 15-and-a-half-year-olds who all got their learner's permit and were about to drive, I'd probably focus on driving impairment. If it is, sorry, I found the link. If it is people that want to go to college one day, I would focus on the cognitive impacts. So I really think I would do everything I could to make sure you're meeting people where they are in terms of what matters most to them. I just put in the chat, this is from cannabisevidence.org, clinician resources. I'm honored to have written and co-authored one of these briefs. It is absolutely fantastic. And they have effects of prenatal cannabis use. They have the impact of cannabis use on female fertility. To the person that asked that question, I would check this out. It's an extraordinary resource.
Perfect, thank you. I think that's the last question that we have time for today. So I just want to thank you again, Dr. Kilmer, sorry, Jason. And thank you. Thank you all for attending today's webinar. We hope you found it both informative and interesting. We would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. Please use the link in the chat or the QR code on the slide to complete our feedback survey. As a reminder, this live webinar has been approved for 1 social work credit, 1 McBack credit, 1 Mishwa credit, and 1 CHES credit, and then 1 CME credit hour. If you're requesting any of these continuing education credits, you must fill out the evaluation form with your name and email address. For the next presentation in our series, Dr. Young-Wolf will be presenting cannabis use during pregnancy, research from policy to practice, and that will be next Tuesday at noon Eastern Time. If you have not yet registered for the other webinars in this series, you can do so by using the link in the chat or visiting washtenaw.org/marijuana. We hope to see you at the next webinar, and we thank you all for your participation. I will stay on for a little bit just to give folks a chance to use these links. But otherwise, that's all we have for today. Thank you all for joining.